So today we are going to just talk about sort of myopia in children. So if you have kids, you have grandkids who are on the screen a lot, this is a pertinent topic to you. And so let's get started. So myopia in children, what you need to know. I have no financial disclosures. So first I will start off with how do we see, right? Our eyes are as a structure that takes in light and it will project it to the back of the eye, which is the retina. And then it goes through the optic nerve into the brain where it is interpreted. And so when we talk about the eye, we actually talk about this piece of structure called the crystalline lens. So the lens, which is like the focusing part of our camera. And then we talk about the retina, which is the film of the camera, where you actually get the images, and then the optic nerve transmits everything to the brain for interpretation. And so what is myopia? Myopia is also called short-sightedness or nearsightedness. It's actually just simply means that things far away are blurry and things up close are clear. And so oftentimes the kids will squint to see things that are far away, but they have no problems with reading. What happens in myopia? Well, in a normal eye, the light goes through the lens and it gets focused by the lens on the retina perfectly. And so the light here gets focused right on the retina, so no myopia. When you have myopia, the eyeball is too long, or the lens is too strong. And so what happens is the light goes through the lens, but however, it doesn't get to the back of the retina. It actually stops short of the retina, hence short-sightedness. And so the eyeball is too long and the light focuses in front of the retina, and that's what we call myopia or nearsightedness. And then just because we are talking about just focusing problems, there is hyperopia or farsightedness, which is the counterpart to myopia, which is where the eyeball is too short, and so the light gets focused behind the retina. Or something that you may have heard of, which is astigmatism. This is actually has nothing, it doesn't really have anything to do with the focusing, but it has to do with the shape of the cornea or shape of the eyeball is how we say it, where, a completely spherical cornea is called like a football shape, like a soccer ball shape. And then if your cornea is shaped more like an American football, then when it bends the light doesn't get focused on one single point and it gets blurred. So if you hear these terms, those are all types of focusing issues. One other common focusing issue is what we call presbyopia. Presbyopia is what we get when we get to 40, 45, 48, 50, is where we need to get reading glasses. And this means that the lens becomes more rigid and cannot change to focus as easily. So remember, I said the lens focuses for us. And so with time, what happens is the lens is not as good at focusing anymore. And therefore, you have to hold things further away from you to read them, or you have to wear reading glasses when you're older. And that is the result of presbyopia. Okay, so difficulty with focusing at near. So let's go back to talking about myopia. So what happens to myopia over time? Well, as the kid grows, your myopia will get worse. This is classically what we call myopic progression. So for example, if you look at the prescription of this sample child, at age 7, they're wearing a -1 or a -2. But as they grow, they go to age 8, age 9, age 10, 11, 12, 13, 14. It gets worse year after year. And that's really the reason why, the reason why this gets worse year after year is because the eyeball grows, just like a child grows as they go through, their early childhood and through elementary school, they actually grow quite a bit lengthwise, so get taller as well as, and so their eyeball grows as well lengthwise. And so as the eyeball grows, it elongates in the axial way, so it elongates, and therefore the light doesn't get focused as well, and so they get myopic. And so as it gets, kids usually go through a small growth spurt between 9, 11, 10, 11, 12, their eyes grows longer, and then that's why the myopia gets worse as well. Okay, Why is this a problem? Well, we don't want kids to have myopia that is what we call pathological, which is high myopia. Anything that we measure above 6 diopters of myopia, we consider pathological or high myopia. And the issue becomes that you have secondary complications from it. And so the retina it stretches and it's thinned out. So, for example, in the picture in the left, you see a normal retina. In the picture in the right is actually a patient who has high or pathological myopia. Because the retina starts to lose its integrity as it stretches, you see these areas of like patchy, thinness, and this is an area of concern. And so, as the degree of myopia increases, the risk of eye disease increases. Diseases like a retinal detachment, glaucoma, cataracts. So these are, and maculopathy was what I showed you earlier in the prior slide. And so, as you can see, the more myopic you are, the in the prior slide, you have, if you're -9, then you have a 348.6 odds ratio of getting the stretched out retina. And then, for example, retinal detachment, 88.2. So as your myopia gets worse and worse, you significantly increase your risk of these complications. And usually we see it at about -6, -5, or -6. Hence, as you can see, the numbers really jump from one to another. And so globally, myopia is affecting more and more kids. And as you can see, this is a global estimate of what myopia will look like. In 2000, we have 23% of prevalence of myopia globally, but by 2050, we have a 50% prediction of everybody in the entire world of having myopia. So this is somewhat of an issue and almost a pandemic. And so, like I said, if you look, by year 2050, we expect half of the population to have moderate or low myopia, and definitely 10% of the population to have high myopia or pathological myopia. And this is provided by the National Eye Institute. So, nationwide, we recognize that this is going to be a growing problem. So why does myopia occur? Well, number one, it's mostly genetic. So if your parents wear glasses because they're nearsighted, then high likelihood that your child is going to also need to wear glasses. And then also the fact that we have environmental factors, like we have our kids reading more. We don't tend to send our kids outside and play all the time, right? They're saying that our childhood has changed over the past 10 years or over the past 2 decades because of the invention of iPads, screen. And so the more time they spend on doing the screen or doing near work, the higher the risk of developing myopia. Okay. And then I mentioned this earlier. Why does myopic progression occur? Well, children who with myopia they tend to grow and need stronger and stronger glasses year after year. The fastest growth happens between 7 and 10, mainly because that's when the kids grow the most. And it's definitely correlated with genetics and environmental factors. And then how do we kind of assess the risk of having high myopia? So we look at parental myopia. So often if you come and see me, I'll ask you, or do your parents wear glasses? Is it one or both? Or do both have high myopia or wear thick glasses? I look at what your initial refractive error is, meaning that, at your age, what your prescription is. Southeast Asians had a prior prevalence for nearsightedness, whether or not you spend a lot of time looking at the iPad and whether or not you actually go outside a lot. So that is sort of the initial assessment of increased risk of onset, meaning that, early onset, or starting to need to wear glasses at an early age. And then the increased risk of progression, I usually ask you, are you, 9 years or younger? Because like I said, 7 to 10 is when it's the fastest growth period. Whether or not you have have a genetic predisposition for progression. And then again, ethnicity and refractive error are both features or factors of assessment of risk of progression. And so the actual question that we're trying to answer today is, can we stop myopia or myopic progression? The short answer is yes and no. And I'll go into the details as to why yes and as to why no. So first we'll talk about no. What we can't stop myopia or myopic progression because you can try to prevent it, but once it happens, it happens. It's almost like you want your kid to grow. So if they gain, 2 inches, you're not going to say, "Oh, I need you to shrink back." That's not going to happen. And so the answer no is that you can't prevent a child from growing. So you can't prevent myopic progression if it does occur. However, we have ways to slow down the myopic progression or prevent it from going or prevent the onset of myopia if we can. So a few things that do not retard myopia. So eye exercises, this sells a lot of books, but it really doesn't improve any eyesight. There's two kinds. There's this one where they ask you to look up and down, left and right, and that does not do anything. And then there's this like mechanical exercises where you're doing these rubbing actions on the eye to slow down myopia, and that does not work either. But in terms of what does work or what has been proven to work, there are three big ones. So one, environmental and behavioral, and I stressed on it in the past couple of slides, which is outdoor time and near work. Meaning that you want increased outdoor time and decrease near work. And then the two other features that I will talk about today is pharmacological, which is what we call low-dose atropine, as well as optical, which is considered spectacles or glasses and contact lenses. So first thing, behavior modifications. How do we slow myopia? Well, we limit the amount of time on screens. We spend more time outdoors. So we have this, you've heard of this 20-20-20 rule, which is take a 20-second break every 20 minutes and look at something far away, 20 feet away. And the idea is for you to break your accommodation or break your focusing when you're on the screen, and then relaxing your straight eye focusing muscles and by looking at something far away. And you don't need to do it for a very long time. You just need to sort of break that habit of over focusing up close and look at something far away. So that's why we call it 20-20-20 rule, because it's easy to remember. And then the other one is to spend more time outdoors. So ideally, we recommend 2 or more hours. I know it's very difficult, but luckily, the school, especially in Southern California, the kids spend recess outdoors and lunch outdoors. So I usually ask the parents to do 1 extra hour of outdoor activity every day if they can, and then 2 hours on weekends. And so outdoor activity, just running around, you don't have to do a sport, just even taking a walk are very quite effective in preventing the onset of myopia and slowing down myopic progression. So we encourage kids to really, play outside more and just be kids, really. So next, I will talk about the low-dose atropine. Okay, so what is atropine? Well, atropine is one of the oldest drops that we've used. We've used them in our clinics for dilation purposes. We use it for sometimes kids who's got a lazy eye. We can use it for that. We use it, after patients who had surgery and they need to relax their accommodation or relax their focusing muscles. We use that. So it's one of the oldest eye drops used. But what we've discovered in the past 15 to 20 years is that if we dilute the atropine to 1/100th of its original dosage or original strength, it can actually be used to prevent and to treat the myopic progression. So currently, if you ever are in, if you ever listen or you ever look on the, I'll go back. In the literature, there's 3 doses that we use. We have the 0.01%, 0.025%, and 0.05% for myopia. Currently, this is still not FDA approved. And so if you get this medicine, or if you want to get this medicine, you have to ask one of us to send it to a compounding pharmacy. Very soon, it will get FDA approved. It's actually in the process of getting FDA approval. So hopefully in the next year, we may be able to just send it to CVS Pharmacy, Walgreens Pharmacy, and they will have it in stock. But at this time, if you want to get it, you actually have to ask me to send it to a special pharmacy, and they will compound it for you, as if they are especially making it for you. So I wanted to show you a few graphs to sort of just show you how effective low-dose atropine is in slowing down progression of myopia. So if you look at this graph here, there's on the top line, this is a patient for untreated. So this is, excuse me, the top graph is the treated eye. So this kid, so what happened in this study is the kids actually, there were two groups of kids. One is placebo, which means that the kid had one eye that's untreated and the other eye received a placebo eye drop. Now that's one group. The other group was the group of kids who had one eye untreated, so they didn't get any drops, but the other eye did get drops, and it did get the low-dose atropine. And as you can see, the untreated eye in the atropine group and the treated eye in the placebo and the untreated eye in the placebo group all had progression. But in the treated eye, the atropine treated eye, you can see that there's actually an improvement of the myopia by year 1. And yes, there's still progression in year 2, but it's significantly less than if the patient had untreated or had the placebo eye drop. So this was the first paper that suggested that low-dose atropine was very effective, in the treatment or in the slowing of myopic progression. The side effects of this drop: some pupillary dilation, blurriness at near work, and some glare, obviously all related to pupillary dilation. Okay, so how did we arrive at the optimal concentration? Well, there are many studies that followed after that. And so they tested 0.01%, they tested 0.025%, 0.05%, they actually tested 0.1% and 0.5%. And so if you look on the graph here, the group that did the best was actually the 0.05% atropine. However, the lower dose, the 0.01% atropine, had the least amount of pupillary dilation, glare, and blurriness with work. But the stronger dose kids had a better result. And so hence the reason for why now, if you actually come to see me, or if you see a lot of the other, even the optometrists or the pediatric ophthalmologists who prescribe low-dose atropine, we tend to want to start with something a little bit higher. Okay, so that was low-dose atropine for slowing down myopic progression. What about the question of, can it actually stop myopia from starting in the first place? And this is actually a study that showed that it can. So this is the study that's done in a group of children who did not have myopia. So these kids did not need glasses, they were not nearsighted, and they were also started on these low-dose atropine eye drops. Same thing, 0.05%, 0.01%, and placebo. As you can see, these kids who started on 0.05% had only a quarter of them developed myopia, versus those who had placebo, and even the 0.01% had 45, 46% versus 50%. So you had almost a half of, if you were going to become nearsighted, if you started the drops early, you may not become nearsighted by about 50, by about half of improvement. So that's a sign that low-dose atropine is effective for myopia prevention as well. So next, we're going to skip to the other form of myopic progression, of controlling myopic progression, which is contact lenses and glasses. So a lot of parents will say, well, I don't want to do drops. My kids scream and yell when I'm putting drops in. Is there something else we could do? So this is what we're going to talk about. So can contact lenses slow down myopic progression? Well, there are two different contact lenses that are out in the market that's designed for this. One is called Ortho-K, one is called peripheral defocus lens. So the Ortho-K picture is on the left, and the MySight, or the peripheral defocus lens, is on the right, and we'll go through with each of them. So orthokeratology, essentially what it does is here is the shape of an eyeball. Okay, shape of a cornea, excuse me. The orthokeratology is a hard, rigid lens that actually pushes on the eyeball during sleep. So the kids wear these hard contacts during sleep. And in the morning, when they wake up, you see how the curvature of the cornea changes from this rounded appearance to a more flat appearance. And so this flattening effect is what actually helps keeping the focusing power at bay, and therefore the kids don't wear glasses during the day. They just wear the ortho K at night to try to help with correcting their myopia. Okay, the only downside is the effect of this ortho K wears off throughout the day, and so beginning of the day they're pretty clear. They're not myopic. They can go to school and do pretty well. Toward the end of the day, the cornea goes back to its original shape, and so it loses the effect. And the other thing is you have to wear it every day for it to be effective. So if you forget to put it in one day or 2 days, you're going to be blurry the next day. Okay. Um, so the only downside to orthokeratology is there is an increased risk of having infection. Yeah, right. We're always told that you never have to wear, you never should wear contacts to bed. And the reason is because it harbors a source of infection. So if the parents are not vigilant, if the parents are not careful, there are kids who get an infection by wearing ortho K, and then unfortunately it's not a good infection, and so they end up either losing the vision or they get a really dense scar and they can't see out of it. And because of that, a lot of the studies were stopped prematurely because of safety. But I'm not saying that it's ineffective. It was just that it was a big risk for the parents to do it. So now let's talk about peripheral defocus lenses. So this is the mice that I was telling you about before. And before we talk about those, I do need to sort of go into this idea of peripheral defocus. It's not the easiest concept to understand, but I hope I can do it justice. So the idea is, right, I mentioned earlier, when you have, what is myopia? Well, myopia means that when the light comes in, it doesn't hit the back of the retina. It gets focused anterior, in front of the retina. And that's why the kids are blurry. When you put a lens, a piece of glass, whatever the glasses is that the kids wear, what the glasses does is it refocuses the light so that it hits the back of the eye, the retina. However, a lens that we prescribe normally also, so the light is not just in one direction, right? Light comes to us in different directions. And so the idea of just one beam getting focused in the back of the retina, in reality, is multiple beams going everywhere and getting focused on different portions of the retina. So if the lens focuses the light exactly on the retina in one spot, does it actually focus the light exactly in the same spot in all the other parts of the retina? Or is it off in terms of, is it defocused in the other parts of the retina? And so in reality, it's defocused, meaning that in the fovea, in the center part of the retina, the myopic glasses focuses the light right onto where it needs to be. However, in the periphery, it actually goes beyond. So it's actually the glasses are too strong for the correct focus when it goes outside of that central viewing area. And this is what we mean by peripheral defocus. That actually the glasses itself is too strong for the kid, and so yes, they can see clearly when they're looking at something, but when you're going out to the periphery, you're actually focusing outside of what you really need to be. And the idea is this kind of peripheral defocus stimulates the eyeball to grow. So the eyeball wants to grow to be able to focus in the periphery as well. And so the idea is it gives you a drive to make your eyeball grow longer, which is the reasoning behind myopic progression. Okay, so the most ideal correction would be a lens that could get you on the retina when it's directly the light that goes directly into the central part, but gets into the other parts a little bit less so that you don't get this peripheral defocus. So this is the lens that is what I'm talking about. Normal lens, normal nearsighted lens like this, it gets outside of the focal area, outside of the central part. But if you're able to get the lenses that's a little bit different, perhaps we can bend the light differently to get the light to focus exactly on the retina everywhere. Okay, and that's the idea of this contact lens. It's really alternating zones of treatment, creating what we call a myopic defocus. So centrally, you are right on focus. Peripherally, you're less and less in focus, but in the ideal manner. Okay, so what do the contact lens studies show us? Well, it seems to be that it did slow by 25% more for these kids who actually had the contact lens, which seems to be pretty promising. And similarly, the glasses that does the same thing. Oops, sorry, I went a little too fast. The glasses that does the same thing, there are two different glasses in the market. You may have heard of this, especially if you come from overseas. They actually market this a little bit more aggressively over in Southeast Asia. Here, they've just received FDA approval, so we haven't actually seen it in production here. And that's the reason why you don't hear about it. But, like I said, if you're from overseas, you'll have heard about this for sure for your kids. And it's the same idea. The lenses are made, so these are just normal glasses. It's actually not that visible. I know I make it look like you can see the little rings, but it's not visible at all when the kids are wearing it. Obviously, if you tilt it to the light, you will see it. But the same idea, it's to try to simulate peripheral defocus for the kids. Whether it's a ring pattern here, or whether it's focused in the center, both of them do very similar things. And so the results in multiple studies show that both these two types of lenses that I showed you earlier did show some reduction in myopia progression. And it, 60%, 67%, those are really good. And this seems to have sustained efficacy over 3 to 6 years without rebound effect, which is also what we're looking for. Again, the glasses or contacts are for kids who actually already need to wear glasses. So you can't wear them to prevent anything because, these glasses are designed for kids when they actually have myopia, or the contacts are designed for kids when they actually have myopia. So I don't have any data to suggest that it's for prevention, but it does seem that it helps with slowing down the progression of myopia. And actually, the question of, so can I do both? Of course, I think if you do, myopic defocus lenses plus atropine, there probably is an additive effect as well. Okay, so in summary, we talked about myopia prevalence is increasing. There are treatments to slow down myopic progression. Treatments are needed for many years, and you actually do need follow-up. It's just not like I can put you on this eye drops because there are titration related to the eye drops. We start at one dose. Is that enough? Is that not enough? And then we do need to watch and adjust based on how fast you're growing, based on how your eyes are, changing year after year. And it's year after year. It's not just 6 months of treatment. It's not just a year of treatment. It's actually probably 3 years, 5 years. If you start, at age 6 or 7, I'm having you do it all the way till you're 13, 14. So it's many, many years of doing eye drops every day, or many, many years of doing, contact lens, et cetera, et cetera. And so, my recommendation is if you have a child who you think, yes, they're at a higher risk for developing nearsightedness because of family history, or you have a child who is already wearing glasses and they're progressing, they're changing their glasses every year, and you're like, wow, they went from -2 to -3 to -4 year after year, then I would talk to your pediatric optometrist. You could talk to your optometrist, and you could talk to one of us to see if there's anything we can recommend to slow down the progression. And then lastly, what's our goal of doing this overall is really I don't want the slope of the curve for a child to be this gray line where it just gets worse and worse and worse. I want to change the slope. I want to slow down their progression. So ideally, with doing myopia control, you wouldn't go from -1 to -4, but you would actually just kind of slow down, plateau at -2.5. We really want to prevent the high myopia or the pathological myopia that we see when you're older, that you have complications from it. We just want to keep you nice and low. Yes, we know that there is myopia. Yes, we know we can't avoid screen time. We can't avoid the fact that our kids are doing, are reading more. They're academically being challenged, and et cetera, et cetera. But our goal is to slow down the myopic progression so that they're not wearing thick glasses. They're not having all the issues that's associated with having high myopia. And with that, that's all that there is I have for you. And thank you for coming.